Dr. Roelands. I'm an OBGYN. I practice general OBGYN, and we'll kind of go through that a little bit as to what type of jobs and things that you can have in OBGYN. I also am the founder of Well Woman MD, which is a holistic GYN business. So I offer digital courses and coaching, and I'll go through a little bit about that too, because I think it's important for people to understand kind of what options you have in OBGYN. There are a lot of physicians now that do things on the side. So I think it's nice to sort of get an idea as to what things are out there. So a little bit about me. So I graduated from UC Santa Barbara with a Bachelor in Science in Physiology. I didn't know what I wanted to do with my life, so I actually jaunted off to Central America doing ecology research through UC Berkeley and spent a year in Central America doing that, and actually applied to medical school while I was in Central America. I went to medical school at UC San Diego. I did my first year of residency, or your intern year essentially, at Cornell in New York. And then I went off to residency at Duke. I finished, by the way, in 2008. So I've been in private practice since then. So private practice, I work in Columbia, Missouri, essentially at a community hospital. We have a academic center about 1.5 miles away. So it's a very small community of about 100,000 people. I've been there for 13 years. In medical school and then in residency, I was introduced to the robot. The Intuitive Surgical has a robot for performing surgery. And so when I got out, I became a proctor. So I traveled the country and taught people how to use the robot for surgical services. And the nice thing in private practice, also academic medicine, you can actually be a part of leadership opportunities, and you can be a part of your community. So since I was the only one using the robot in my community hospital, I created a robotic committee, and so ultimately ended up adding urology and cardiothoracic and all these other specialties, a way for us all to kind of talk together about what services we needed for the robot and to bring that out to the community. So I was involved in leadership positions in the hospital. Last year, I founded a business called Well Woman MD. It's a holistic women's health and wellness business. And I started this because I had suffered, or I have, an autoimmune disorder. And it took me a really, really long time to figure out that nutrition was key to me healing myself. So I spent years and years in infertility and all kinds of struggles, and ultimately realized that the way I could heal was by solving my own gut issues. And so I created this company last year because I really wanted an opportunity to help other women who didn't have to go through those years of struggling like I did. So I'll talk a little bit about that throughout here, because I want you to understand there are definitely people who take the traditional route of medicine, and there are definitely people who take both the traditional and holistic route. Right now, I'm actually in the Integrative Medicine Fellowship currently, and I can certainly answer questions about that too. I have 4 kids, lots of craziness at my house. So I understand juggling multiple things. Those are my 4 kids. And I've sort of become a mama baker because I made the mistake of making their cakes by scratch every single year since they were babies. So every year it just gets harder and harder. They start making them harder and harder. That's my dragon cake at the bottom. That was fun. Okay, so this is the side gig that I was telling you about. So I actually have a podcast. It's called Ignite Your Power Podcast. And this is really bringing women experts in women's health into the podcast, and also talking about women's health issues in general. My business is called Well Woman MD, and then also I'm in an Integrative Medicine Fellowship. And for those who don't really know what integrative medicine is, because I think it's a really, really new field, it also can be a little bit confusing. Most people think of it as alternative medicine, but integrative medicine really is a complementary and conventional approach put together in an integrated fashion. It's really science-backed. I mean, it's different than sort of functional medicine or alternative medicine, where it's just less mainstream. So, and I'm happy to answer questions about that too. Okay, so if you want to become an OBGYN, you have to do an undergrad degree. Most people do an undergrad degree in a science major, although there are certainly people in my medical school class who were religious studies majors or English majors. You really just need to get an undergrad degree. You need to make sure, if you're interested in medical school, and I'm sure you guys have heard this before, you have to be involved in some degree of like an internship or shadowing or volunteering, something in the medical field, so that you show your interest in that you've done things outside of just going to school. You go to medical school, it's 4 years. And then for OBGYN specifically, it's a 4-year residency. And then if you're interested in subspecialties, OBGYN has 3 that are 3-year fellowships. That's maternal fetal medicine or high risk OBGYN, reproductive endocrine and infertility. That's helping people get pregnant. Urogyn, so this is mostly with women with incontinence or prolapse, any sort of urology. It's a really interesting marriage of urology and GYN. And then MIGS is a 1-year fellowship, so minimally invasive gynecology. This is where you learn advanced laparoscopic skills and robotic skills. It's a 1-year now board certified fellowship, and they're everywhere now. It's a pretty big fellowship now. At the time, just in case anybody wants to know about the robot, when I got robot trained, MIGS was brand new, and so they didn't really have a formal training for the robot. But now in residency, when you leave residency, OB/GYN residency, you're formally trained using the Da Vinci. So the options for jobs, this has really changed since I first got out 13 years ago. In the past, it used to be just you picked private practice or academics. Now, over the years, they've really focused on lifestyle and trying to help people have a little bit better of a work-life balance or work-life harmony. And so the options are more. You can work in private practice. You can work in an academic center. You can work GYN only. Some people never do OB. They actually drop the OB portion and ultimately end up with a GYN only career. And those people would likely have privileges at a hospital, so they would see women in their clinic, but also operate through a hospital. And some people actually just do GYN only and never operate as well. There's now an opportunity to be a hospitalist. So if you like inpatient care and don't really have that much interest in doing outpatient or continuity of care, then hospitalists essentially cover doctors for a 24-hour shift. Most hospitals around the country have really made their own hospitalist program because they want to be able to offer options if, say, a physician goes on maternity leave or medical leave, they need to be able to cover those particular patients. And so hospitalist programs are becoming very, very, very popular across the country. And then locums, where you're covering doctors who have a private practice or an academic practice, and they want someone to cover for, say, a 2 or 3 month block. So someone may get injured and need somebody to cover for like a 2 or 3 minute block. So locums, most people travel around the country, and then they have these assignments that can be anywhere as short as 3 months and up to a year, depending on what the needs are of the hospital. So typical day in OB/GYN practice. So since this is me, I thought we would kind of just talk about what do I do? So the most important thing about being an OB/GYN is there is no typical day. Things are usually whatever happens. So today I woke up 6 o'clock and I looked on the app I have for the hospital, electronic medical record. I noticed there was a patient of mine in labor. I had 3 people that had been in labor over the weekend and now were postpartum. So on a typical day, today I'm off, but on a typical day I would wake up and say, okay, well, I got to get to the hospital because there's a patient in labor and I need to be able to round and I got to get to my clinic by 8:45. So you're always constantly balancing, what you got to get done and how the day unfolds, because who knows, you could be in a day of clinic all day and you could be laboring a patient and in clinic. For private practice, a full-time clinic schedule is usually seeing about 40 to 50 patients a day. Most of these are 15-minute slots. I'm usually double booked, sometimes triple booked. It just depends on what the flow is for the week, I suppose. OB patient visits are usually fairly quick. So most people, 5, 10, 15 minutes. It just depends. If someone's third baby, they're usually in and out pretty quick. GYN patients visits tend to be a little bit longer. So somewhere between 15 minutes to 30 minutes. In my private practice setting, I have to do 24-hour call, and that's about 4 times a month. In private practice, it depends on the number of people in your group. I have 11 doctors, or 10 now, in my group, and so we have less call. So a typical average OB/GYN private practice group in the country has about 6 to 7. That's the usual. So they're taking around 5 calls a month or so. And most of these are 24-hour calls. You do have the option to work post-call or after your 24-hour shift, then go work in clinic. I used to do that for about, 8 years or so, and then I stopped doing that, which was like the best thing ever, because you're tired. You're tired, and also you can't really give yourself and really be a good physician if you kind of are cranky. So I gave up that about 2 or 3 years ago, and that's been a great decision for me. In an academic center, Most academic centers work differently because they want someone to be in clinic, they want somebody to be in the operating room, they want somebody to be on labor and delivery managing residents and medical students. So it's not, you're not doing everything all at one time like you are in private practice. When you're in private practice, everything you do is your schedule and you're managing all your patients, whoever comes in the door. But in academic centers, they usually try to structure it to where someone is managing labor and delivery, someone's managing the clinic, and someone's managing their operating room day. So it's a little bit different. You have very set hours, so it's going to be an 8 a.m. to 5 p.m. day. If you're not busy in clinic, then you're usually doing something with medical students or residents teaching. Sometimes they have built-in research time, depending on how you structure your job. So some people love to do research, and so they may have 1 day a week doing research. And sometimes people have leadership roles that they have built into their schedule as well, so that they can actually, you know, build up the medical student program or change the curriculum in the residency. So you can have some flexibility in how you create the job that you want, but most of the time it's a very structured setup, which they need it to be. They need to be able to make sure they're covering all their locations, essentially. Typical clinic day for me, so I see yearlies or annuals. I can see return GYN problem visits, so people who have irregular periods, they want to talk about birth control, may have pelvic pain or have issues with vaginal discharge. Usually I see new OBs and with their ultrasounds on the same day. I read my own ultrasounds, so that's different than in private practice. In academics. In academics, you have someone who's a radiologist or sometimes a maternal fetal medicine doctor who's the high-risk doctor who reads the ultrasounds. But in private practice, you have to read your own ultrasounds. And then I'll see return OB appointments, and sometimes those have possible evaluation with ultrasounds as well. Typical call day is about 24 hours. You're essentially the one person. We have no ancillary staff, so I don't have a PA or a nurse practitioner with me, so I have to manage all the patients in labor. Any triage that walks through the door, either through the emergency room or through labor and delivery, I also manage as well. And if the floor, you know, if someone on a medicine floor calls and says they need help with a GYN patient, then I have to go see them. And then on the weekends, since we cover for other physicians, oftentimes you're rounding on about 20 patients or so in the morning and trying to, you know, see if they're going home or that kind of thing. During the week, the way we have it structured is that we essentially are helping. We don't need to round on other people's patients. We just need to take care of our own. Typical OR day, that's the Da Vinci, by the way. I usually have a pretty full schedule because I have 1 day a week that I'm operating. So I have 2 major cases, which are robot hysterectomies, and then some minor cases that are there. There is no assistant except for what's provided by the hospital. So I don't typically operate with another doctor. And that's 1 day a week. That's the, in case you've never seen the Da Vinci, so that's the actual machine with the arms that help operate, and then there's a console, which I'll show you in a minute. So I thought I would just run through. I saw a great example. Your leaders in this group had a great presentation, and she gave some examples of things that people would likely see. So I just thought we would kind of go through that and a couple of scenarios, both GYN and OB, and just kind of mention some things that you would typically see as an OBGYN. So, and the other reason why I wanted to do this is I wanted to show a little bit of a difference between a conventional approach and an integrative medicine approach. So essentially trying to show you if you wanted to do an integrative medicine fellowship, or if you were interested in more holistic options, how you would essentially treat someone a little bit different. So this is a 25-year-old patient who has irregular periods for the last 4 months. She has periods that range anywhere from 3 weeks to 2 months. They're all over the place. She tells me that she feels bloated, moody, and just hormonal in general. She's very healthy, no medical history, no surgical history. She's never had children. So things you're going to think about to ask her, you're going to ask her, how long has this been going on? Do you have other symptoms? What, like other hormonal symptoms like weight gain, weight loss, hair loss, constipation? Do you have acne, hair growth that's excessive or dark in color? Are you trying, what is your contraceptive plan? Like, are you trying to conceive right now? Are you hoping to be have something to prevent pregnancy? Have you had any blood work? Have you been evaluated for this problem before? And then what have your periods been like before all this started? Were they normal? Have they always been abnormal since the day you started? What is the essential menstrual history, as we call it in medical school? So and while this person, you're asking these questions, in the back of your mind, you're trying to come up with a differential of options that this could be. So in your mind, you're thinking this could be PCOS, this could be anovulation or not ovulating due to her being either underweight or overweight, and that causes a problem with your hypothalamus. It could be a thyroid problem. She could have diabetes. She could be taking a birth control wrong. Sometimes people come in and talk to me about irregular periods and they just don't know how to take the birth control pill. Or they're taking supplements over the counter. There's a lot of supplements that interfere with your hormones, and unfortunately, there's no way to know what's in them unless I always ask the question when people come in for any sort of irregular bleeding, like, are you taking anything else? Because oftentimes women think it's just a natural option, like I'm taking this supplement and it's going to help me feel better, but they don't realize what's in it and don't pay attention to the ingredients. Sometimes it can be related to too much exercise or too much stress. So in the back of your mind, you're always, as an OBGYN, you're always, or any physician, you're always thinking, what could this be? What could this be? And running through those different things in your head. So she answers these questions, which are that she's been having irregular periods for 2 years. She does have excess hair growth on her chin and her belly. That's darker, kind of coarse hairs. She's not interested in having a baby right now. She also reports she has a hard time losing weight. She's been trying to lose weight for the last several years and just doesn't seem to be able to get it to work. She's never been worked up. And then when she was on birth control pill a couple of years ago, her cycles were totally normal. So in your mind, you've kind of gone through that differential that I was mentioning, and you're kind of leaning towards PCOS. So in PCOS, which we'll talk about, you're going to so as a physician, your goal is to really try to help a patient understand what are the options it could be, and then what does this mean to them? Like, what is PCOS and how is this going to either help or harm me? So you're going to explain what polycystic ovarian syndrome is. You're going to talk to her about blood work that she needs. And the blood work is going to include a thyroid panel, total testosterone level, FSH, DHEAS, which is sulfate, and prolactin level. And you want to get this blood work always at the beginning part of a cycle because the normal lab values are based upon the first half of the cycle. So it does you no good if she says she's on day 46. There's the lab values don't go through past the normal cycle time, which by the way is 21 to 35 days is a normal cycle. If you're less than or greater than that, then that's not normal. Okay. Polycystic ovarian syndrome. So it's called a syndrome, which means you have to basically eliminate everything else. You have to say it's not, it's diagnosis of exclusion. So criteria for diagnosis is irregular cycles and evidence of male hormone levels elevated by both blood work or physical signs. In the past, you actually see cysts on someone's ovaries, but now it's not a requirement, not part of the criteria. It's sort of like a bonus if you do. That's that string of pearls that we see on imaging. The problem with PCOS, or the complications that can happen, is that we think that PCOS patients are essentially like a pre-diabetic, or they're destined for diabetes and metabolic syndromes. And so you want to help them optimize their health so that they don't eventually become diabetic or eventually end up having issues with obesity and cholesterol and all the metabolic syndromes that most people recognize. The other complication related to it in my world is that oftentimes women with PCOS have infertility. They have a higher chance of becoming gestational diabetic once they actually are pregnant. And then they often have higher rates of miscarriage in the first trimester because of their insulin resistance. So you want to be able to talk to them about, where are they in their life as far as trying to have a baby? Or are they trying to wait till down the road and they have time to optimize their health before that? You kind of want to assess where they are to meet them where they are. The other thing that's important about this is that there are other sort of syndromes associated with PCOS. So oftentimes there's an anxiety or depression component. Some people have sleep apnea if they're overweight. So ultimately, working with them to try to optimize their health and get to an ideal body weight, which is what we'll talk about, is really important, regardless of whether or not they're interested in conceiving right away or not. So in a conventional approach, so in my day job, essentially, I would talk to her about, if she's not interested in having a baby right now, about birth control pills. Because what you're trying to do is lower those male hormone rates and essentially regulate her hormones. So you want her to have a normal estrogen, progesterone, testosterone ratios. And so birth control pills essentially create that ideal environment. So you're going to offer her a birth control pill. You're going to talk to her about weight management and getting to her ideal body weight, and in order to, essentially decrease her risk for metabolic syndrome and diabetes long term. So this is usually, as you guys know, 15, 20-minute visit, someone comes in, you talk to them about PCOS, you explain what it is, and then you offer them a birth control pill and say, you should probably lose weight. In my mind, where we're lacking in medicine, where it's a problem, is because essentially on an integrative medicine approach, you take that time to say, what is it about essentially the other components of their life that are going to interfere with their ability to get healthy? So maybe they don't sleep at night. Maybe they have crazy high levels of stress. Maybe they smoke. Maybe they drink too much. So you don't really have time in sort of a standard office visit to kind of go through what might be the obstacles to their care, what might be the obstacles to them losing weight. You also don't have time to sort of go through the optimal diet for PCOS. Not all diets work for women with PCOS. If you have it, which I do, that you can't just go, I'm going to go on a keto diet, it's all going to be great and everything's going to be awesome. There's certain diets that work better than others for PCOS, and there's certainly different types of PCOS. So you have time to sort of go through and say, let's kind of talk about your life and what things might be challenges for you, and let's find the right diet for you. You also have time to go over optimal exercise, because I think in general, most physicians sort of say, well, you just need to exercise. Well, what does that mean? Like that's a lot of a very vague and generic statement. So you can talk to women about exercise options that work for them. You can also talk to them about natural fertility options, including supplements if they're interested in having a child. And then you have time to follow up with them and say, well, okay, this didn't work. Let's pivot and go somewhere else. Let's figure out a different option for you. And then there's an interesting new, it's not new, but there was a fantastic biochemist who created this sort of concept of cycle syncing, which essentially says that in certain parts of your cycle, you have to sort of plan your diet and your exercise around those certain phases in your cycle. And it is based upon where your hormone levels are. And so in cycle syncing, you want to sort of say, okay, I'm in my follicular phase, or the first 10 days of my cycle. These are when my hormone levels are rising. This is when I should try to use this type of exercise. I should focus on these type of foods. So it's a really interesting approach for women who are not interested in birth control, but want to optimize their health and ultimately know a little bit more about their body, so that when they're trying to have a baby, they can understand, when they're ovulating and that sort of thing. So these are kind of, I wanted to show you this only because I wanted you to understand what integrative medicine versus conventional approach means. And so I'll mention it again on one other slide talking about an OB scenario, but I think sometimes it's hard to understand kind of how those things are related in a way. Oh, clinical, here we go, OB scenario. So you have a 28-year-old new OB patient who has nausea, vomiting. And these are just all scenarios that I typically run through in my practice that I see pretty common. So her past medical history is only that she has Hashimoto's thyroiditis. So she has an autoimmune disorder where her body attacks her thyroid. She has no surgical history. She's now pregnant with her first child. She's only on Synthroid, which is the medication for hypothyroidism. It's the most common medication. So essentially she has hyperemesis gravidum, which is, the definition is just severe nausea and vomiting in the first trimester. Usually it resolves by 12 weeks because your hormones just skyrocket in the first trimester. And so when it starts to plateau off, you generally get better. Unless you have twins, then sometimes that continues for a little while. Or just unlucky, occasionally there's that one woman that just is sick her whole pregnancy. And there's not much reason, medical reason or physiological reason, it's just her and her body and pregnancy didn't really agree. So ultimately, first of all, you always want to decide in this scenario, does this patient need to be in the hospital? Can they tolerate anything by mouth? Are they able to keep some liquids down or some food, but ultimately they're just mostly sick or feel nauseous all the time? So you decide that she's an outpatient candidate because she's able to have a little bit of something, but just overall feels pretty crummy. And so a conventional versus an integrated medicine approach, in a conventional approach, you're going to offer her antiemetics, which are nausea medicines, the most common being Zofran, Phenergan, and then the new one is called Diclegis. Diclegis is essentially Unisom and vitamin B6, which I put the third one down, it's just they put them together. So Unisom and vitamin B6 are available over the counter, but Diclegis, the company, was smart enough to stick them together and create a drug, essentially. It is the only FDA-approved medication for nausea in pregnancy, but most, if you're involved in the women's health field, you know a lot of medications, the categories for medications A, B, C, D, X aren't really fair because it's very difficult to study medications in pregnancy because women don't want anything to do with pharmaceutical companies, and pharmaceutical companies want nothing to do with pregnant women. So it's often very difficult with those categories. I usually tell patients, you know, they're kind of unfair. There are medications we know that are safe in pregnancy, like say Prilosec, that's listed as a category B. Like it's just because they haven't done randomized controlled trials on that medication, but it has nothing to do with pregnancy. It's just that it's difficult, like I said, to study pregnant women in general. So that's a conventional approach. An integrated medicine approach is we're going to talk a little bit about lifestyle factors. We're going to talk about a thyroid, hypothyroidism, and pregnancy, because there are actually optimal diets for women with hypothyroidism or low thyroid, underactive thyroid. There's also optimal exercise routines for women with autoimmune diseases. And there's also a need for women who have autoimmune issues to supplement because they often are micronutrient deficient. And so selenium, zinc, iodine are three micronutrients that often women with thyroid problems or autoimmune issues are deficient in. And so especially when they're pregnant, you want to make sure that they're getting enough for themselves as well as their child. So we talk a lot about, you know, what's your diet? If you feel terrible and you're not eating much, then you're definitely not even getting enough for yourself. So you need to use supplements to help that. And then we also sort of add in essential oils for nausea in general. And then acupuncture, there's so much good data on acupuncture and helping with nausea. There's tons of good data on IVF, actually, improving the IVF rates for women who underwent acupuncture. It's all over the literature. It's just that, you know, in conventional side, you can't essentially get people to, you know, insurance companies to pay for it. So it doesn't seem to be in that kind of realm. And then we often suggest ginger and lemon tea to help with any GI problems, really. It's very good for nausea in general, even if you're not pregnant. So here's a GYN scenario. So, and I bring this up because we're going to talk a little bit about the operating room. Essentially, this is a 45-year-old female who is a G3P3, so she's had 3 children. She came to me with heavy periods of the last year. They're painful. She passes a lot of clots, and each time her period is really long, about 7 to 8 days. She got no medical history, no surgical history. She had 3 successful vaginal deliveries. You did some blood work and you found out she's pretty anemic. Her hematocrit is 30. She should be about 45 to 50. And on ultrasound, and usually people, if you suspect they have irregular periods that are heavy, especially if they're becoming anemic, you really want an ultrasound to evaluate what's going on. Is it a structural problem or hormonal problem? That's usually where you're sort of starting out your path of figuring out what things are wrong. So on ultrasound, she has a 6-centimeter myometrial fibroid, so it means it's in the muscle of the uterus. Fibroids are essentially benign tumors. If you have family members who've had a hysterectomy for fibroids, they'll often say, I had a tumor. They're essentially benign tumors that cause the uterus to be bulky, so people have pain. They also cause the uterus, they also push in the lining of the uterus, which tends to cause people to have really heavy clot periods and often become anemic. She tells you that she's done having children. And for part of your evaluation, you should always do a good exam on everybody. Nothing substitutes for a good exam. I'm a big advocate of, you know, even if you get an ultrasound, you still need to do a good exam. You need a pap smear to make sure she doesn't also have cervical issue, and then endometrial biopsy, because anybody over 35 who has irregular bleeding, you want to make sure that they don't have a cancer, because at that point, when someone's diagnosed with cancer, they leave a benign GYN setting and they need to go see their GYN oncologist, because that's I didn't put that in this special, I'm sorry. There's a subspecialty called GYN oncology, which is cancer doctor for GYN. I just realized I didn't put that at the beginning part of possible specialties. So you evaluate her and she's got fibroids. We talk about the options. What are the options if you have fibroids? Well, there's a medical management option with birth control pills. Sometimes it works, and this is barring that they don't have a reason they can't be on birth control pills. So anybody who's 35 over 35 who smokes or has, heart disease or diabetic, they're not probably a great candidate for birth control pills in general. We want to increase their stroke risk or their blood clot risk. Sometimes it works with birth control pills, sometimes it doesn't. The issue is really that it's a structural problem, and then you're trying to fix it with hormones. So sometimes it works, sometimes it doesn't. The other option is a less invasive than a hysterectomy, but it's called a uterine artery embolization. And I'll mention that on the next slide. And then the ultimate option, definitive surgical management, is with a hysterectomy. So uterine artery embolization, this is done in radiology. So there's a subspecialty of radiology called interventional radiology, and those guys have really, their field has just expanded. I mean, it's amazing. And it's great, really, from my standpoint too, because oftentimes you can use interventional radiology to do things that you would normally do surgically, but now you have a less invasive option for people. So this is an example in my world where interventional radiology it does help for avoiding a more surgical, more invasive option. So UAE, essentially what they do, and this is a picture of it, they take a catheter and feed into the uterine artery and oftentimes try to find the branches that go to that particular fibroid. That white whirly thing is the fibroid. And then they put these little particles, embolic particles, that go into that vessel that feeds that fibroid, and it clots off that vessel. So it stops the blood flow to that fibroid. Fibroids like blood flow, they steal it from the uterus. And so when they do that, they grow, like Miracle-Gro. So if you cut off their blood supply, they're not going to do that anymore. It's really much more successful in women who have just a single fibroid, or like say a big, large 6 centimeter like her. If you have someone who's a bunch of little tiny ones, it's very difficult for the radiologist to go in and try to isolate all these different fibroids. So it's less successful. The downside is that sometimes people after this procedure get terrible pain and fever, and they often have to be admitted to the hospital because they just get, because essentially you're causing that tissue to die. So it causes a reaction in your body where they have pain and fever. I often counsel women on this option that sometimes they ultimately end up in hysterectomy, that it doesn't always fix the symptoms. It's really hard to predict how successful someone will be for this procedure, because what happens is the fibroid starts to shrink. And when it shrinks, you never know how much pain, how big the fibroid has to be to cause pain. So I tell people your pain might get better, your bleeding might get better, whether or not it's to the level that you're happy with, it's hard to predict. And so we often just talk about the pros and cons. And anytime you counsel a patient, you always want to talk about the risks and benefits, right, to the procedure. And so women who typically choose this option, in my opinion, are usually women who have one fibroid, and they may be, say, 48 years old. They're within a couple of years of menopause. So they really only have to get a couple of years of relief, because ultimately when they go through menopause, fibroids don't tend to cause any problems because they like hormones. So if you don't have hormones anymore, they don't tend to have any issues. So this is a non-surgical, less invasive approach than to a hysterectomy. On hysterectomy, this is sort of where it comes into my world. Hysterectomy, the downside is you have to have time off. Now, hysterectomy approaches all dictate how much time you have off. There are different strategies. There is the open technique, which is that incision that's, the horizontal incision that you need, what we use for a C-section. In that scenario, you need about 4 to 6 weeks off, especially if you do any heavy lifting. There's a laparoscopic approach, which is very similar to the robotic approach, typically 3 small incisions. Those incisions are in general less than 1 centimeter in size, and they, because it's less invasive, then most people can go back to like a desk job within 2 weeks. And if they're lifting anything heavy or need to have a more manual labor job, then I tell them they need the full 4 weeks off, because there's a stitch in the back of the vagina where the vaginal cuff comes together, and you really can't be causing any force on that. Otherwise, you're going to end up in an emergency with the bowel that comes through there, which is a big problem. So laparoscopic and robotic are very similar. They're in the same category of minimally invasive surgery. Obviously, the most minimally invasive procedures of vaginal hysterectomy, which everything is done through the vagina. But most people, I mean, to be honest, as the years go on, less OBGYNs are trained in the vaginal approach. most of us have trained in minimally invasive surgery, so we're more comfortable with a laparoscopic or a robotic approach because I can see everything, right? So on a vaginal, your space is limited, and over the years, more obesity has become a bigger issue, so it's often difficult to really get a good view to really see and to be able to operate in a more comfortable manner. But there are a lot of very good vaginal surgeons, and my hat's off to them because you just sort of tend to do what you're comfortable with, which I do counsel patients. The most important part is really, what is that surgeon that you're seeing, that you're comfortable with working with? What are they good at? I think a laparoscopic surgeon is just as good as me. It's really what that surgeon is comfortable with, what their tools that they're used to, and I think that's more important because oftentimes patients will ask me where their friend had an open versus they had a laparoscopic, and I really try to encourage them to say, it's really about the relationship you have with your physician and what that physician is comfortable with doing. If I'm not comfortable with the case, then I give it to somebody else who in my group or to the oncologist who is more comfortable in that scenario. Because you really want to make sure that you stay within your own limits. Got to be careful. And the post-op risks, when they're less invasive like that and they have the smaller 3 incisions, really the pain is so much better than an open. People go home. I send 50% of mine home the same day. And then otherwise they stay overnight. Usually the criteria for them staying overnight is because they live too far from the hospital or they had multiple medical problems, and I would just want to make sure that they tolerated the surgery okay. So, but a lot of my patients want to go home the same day, especially in COVID world. They really don't want to be in the hospital. So we really allow them to go home as long as they have good follow-up and people that can take them to the hospital should there be any problems. This is I include this picture. So laparoscopy is on the left. That's my son, actually. Our hospital is pretty cool because they let the kids come in and play on the instruments. And they call it a family day. So that's my son who's actually practicing picking up a jelly bean that's up there in the left corner on the screen. So laparoscopic instruments are straight. Your degree of motion is 180. You can only move the instruments up and down, essentially. I mean, side to side, but your degree is limited. And then basically, you have to have another surgeon to help you. You have to have an assistant because someone's got to hold the camera and someone has to use the instruments. So I trained in residency. I spent most of my time doing laparoscopic hysterectomies. But as I got into private practice, I ended up converting to pretty much most of them are Da Vinci now because I can do this all by myself. That's my daughter right there. That's the Da Vinci console where you put your face in. Typically you sit on the chair, but she's not tall enough. So it's almost like you're in this, I mean, I don't want to say video game, but it almost feels a little bit like a video game that you're in this console working. And then I showed you can actually see on the right-hand side behind my son here, that's the robot with its arms that end up moving inside of the patient. Just for girl power note, I have 3 sons, 1 daughter. They all did this Da Vinci practice where they did a test and they had to move the jelly beans and they had to actually sew, and my daughter rocked it. She got like 95%, and the boys, she rocked it over the boys. So go girl power. So, oh, it didn't come in here. Okay. So I had a video on here, and this morning I was trying to pull up PowerPoint. For some reason it didn't work, so I ended up using Google. So I would encourage you guys, go to YouTube and just put in Da Vinci grape or Da Vinci grape presentation, and it'll literally show you, it's the coolest video. And essentially the grape, you can peel a piece of grape off and you can sew the grape skin back to the grape. In such, the precision is amazing. So your hands work in the way the robot arms are is you can move your hands 360 degrees. It's essentially like your own arms. I often tell patients it's like having an open procedure because I can move my hands just like I could in an open, but actually laparoscopic. So for me, the advantage is those cases that I would have in the past maybe opened and done an open hysterectomy, those are the ones that I do via Da Vinci because I really think I can get it done minimally invasive and then save that patient so much more time and pain and work time off. So to me, it's essentially a comparison between open and robotic. And I've been doing the robotic approach for, let's see, 2005. So for a while that I've been doing that. I think it's a fantastic option. Oh, here you go. I wonder if it'll, no, see, it won't. It won't play on here. I'm sorry, you guys. So this is, you can actually see the instruments here. It worked on the PowerPoint. It's just not going to work on Google. So see, the instruments are actually small. This is less than a penny. And so the video, which is very cool, they're sewing literally the grape skin back on the grape. This is kind of the picture that you typically see on a laparoscopic case. This is the uterus, and then you have the tube, round ligament. And so you usually see the instruments, and this video is actually a laparoscopic hysterectomy. So just go to YouTube and Google those. There's like hundreds and hundreds of videos. You can see the difference between a laparoscopic and robotic approach. So the OB scenario that sometimes I see, so basically this patient is a 32-year-old G2P1. She's 37 weeks and 5 days. She presents with a headache and just not feeling good. She denies contractions or leaking of fluid and has really good fetal movement. She's got no past medical history, surgical history. A lot of my patients are like this, that typically when they see their OBGYN, they're 25 to 50. Oftentimes they don't have a lot of medical issues because they would have likely had an internal medicine doctor or a family practice if they're on a lot of medication. She presents labor and delivery, and she has a blood pressure of 150/91, and her cervix is 2 centimeters dilated, 75% effaced, and -2 station. That's where the baby's head is, located in relation to her spine. So you evaluate the patient, and I told you her cervical exam already. You decide to get lab work because her blood pressure is high. Anything over 140/90 is considered high in pregnancy. Even if you have a blood pressure of 100/60 when you're not pregnant, we still have a set number essentially that we go off of. You get lab work. Typical lab work for elevated blood pressure includes a CBC, CMP, uric acid, and a protein creatinine ratio, and this is done by a urine sample. So the lab work returns, and you notice that her platelets are low. Anything under 150 is considered low for pregnancy. Her CMP or chemistry is normal, but her protein creatinine ratio, and that's how much protein is spilling into her urine over the creatinine ratio, is 450 milligrams. Anything over 300 milligrams is considered abnormal in the mild range, and then over 5,000 is considered severe range. And during that time, because it takes about an hour or so to get your blood work back, you notice the baby looks fine on the monitor, by the way. You notice that her blood pressures are still high, and they're still over that 140/90 on most of them. So in that scenario, you're going to diagnose her with mild preeclampsia. And the definition of mild preeclampsia in general is when you have blood pressures that are over 140/90 on 2 separate occasions. Those need to be at least an hour apart. And they could be 2 hours, 3 hours, it doesn't matter, but at least an hour apart. And you need to, in that meantime, try to, lay the patient onto her side, try to take her blood pressure on up on her arm, try to take the appropriate blood pressure. Your lab work indicates that she had protein in her urine, so you make a diagnosis because her protein was 400 on mild preeclampsia. And then because you diagnosed her with mild preeclampsia, let me just mention about preeclampsia in general. So the risk factors for preeclampsia are usually your first pregnancy, age, someone who's really, really young, someone who's over 35. If you have a prior history of high blood pressure or say like borderline blood pressure, you're more likely to have preeclampsia. If you have other comorbidities such as diabetes or you're overweight, then you have a higher chance of having blood pressure problems. Race, African Americans tend to have more issues with preeclampsia than other races. IVF also imparts a higher chance of preeclampsia, and then multiples. Multiples, they have a higher risk of everything, preterm labor, everything. Diabetes makes sense, you have 2, right? So you look at her and you say, well, I made a diagnosis of mild preeclampsia. She's 37 weeks and 5 days. Term is anything over 37 weeks. So you make a decision, I'm going to deliver her. Because she's over the chance of needing to be in the ICU care, the baby going to the ICU, if your term is 3% at 37 weeks and less than 1% at 39 weeks. So it ultimately always, in my world, it's always, is it better in, better out, better in, better out. I'm always making the decision all the time on these scenarios, is it better in, better out. So in the scenario, if this woman was say 28 weeks, then you would say, well, this is definitely not better for this woman to deliver. 28 weeks, they have a 90% chance of survival, but they usually have long-term neurological issues, lung issues. So you're really trying to assess their chance of long-term problems, right? So that preterm scenario, you would probably give her steroids to help mature the lungs on the baby. You would try to observe her as long as you can in the hospital. And what you would deliver her for would be if she developed severe preeclampsia, like she was becoming sick, then you're stuck. You're going to have to deliver the baby. So oftentimes those patients end up staying in the hospital for several weeks, sometimes several months, until they ultimately declare themselves as a severe preeclamptic and then get delivered. In this patient, we decided to deliver her, and she had a prior vaginal delivery, so we would induce her, and then success, yay. So I'm going to conclude and say, why would someone choose OBGYN? So in my mind, the typical OBGYN, you have to like fast pace. There's a lot of things going on. You're always managing multiple things, especially when you're on call. Even if you're an academic versus private, you're always having to answer calls from the ER, answer calls from the floor, manage your labor patients. So it's a fast pace. A lot of people who choose OBGYN love surgery and they love clinic. They just can't decide. They're those people that go through their medicine rotation like, I like this. And then they go through surgery and go, I like this. And they just can't decide on a way. And so you get a balance of both, right? You can essentially create whichever one you like. There are definitely OBGYNs who heavily do GYN surgery. They may operate twice a week instead of once a week. And then there are definitely OBGYNs who have very minimal OB. And so they may see 5 people do a month. And so they mostly do clinics. So you can kind of essentially make the schedule that you prefer. You got to love working with women and babies because that's what you do all day. So I'll tell you that before COVID, most of my patients would bring all their kids in because they just love to show me how they've grown up over the years. And so you got to like kids and you got to like moms because oftentimes I'm doing my annuals with moms with all their kids in the room, pulling on stuff and eating lollipops and all kinds of stuff. So you have to be someone who's open to, a little bit of chaos. And then I think the bonus of OBGYN is that you get to basically go through transitions with women. So I've seen some of my patients who were like, say 16 when I first met them, and then now they're having their baby at 22, then they have their second baby. And in that time, I've done their mom's hysterectomy. So you kind of get this, you get to be a part of all these different milestones in a woman's life, and you get to sort of see them transition into different human beings as they grow up. So it's kind of cool in that aspect to see that. And it's definitely cool to see the kids that you every year get to sort of get a little update and see, what they're doing, what they're becoming. So it's a very cool field. So why integrated medicine? I just wanted to throw this in there. So I think this, for people who really want to focus on offering patients other options. So in my mind, in my world, if someone comes to me and they say, well, I don't really want to be on birth control pills, what else you got, doc? To me, it's for me to be able to offer them and say, well, let's talk about nutrition. Let's see what we can do to fix your diet. It's really about prevention. It's about trying to help women with preventing those diseases, preventing diabetes and metabolic problems long-term. You have to understand that food is medicine, that people can reverse their symptoms by simply fixing and cleaning, taking a clean eating approach to their life. And then you're really focusing on the patient as a whole, not just diagnosis and treatment. Thank you. You guys have any questions?
Thank you, Dr. Roelands. That was awesome. Everyone loved all the information. It was really informative. So thank you for providing us with that. We'll do, I guess, a couple of questions. I think towards the beginning, when you were talking about opening up your own company and starting your own business, a lot of people are wondering what background, if any, you had in that and kind of how you managed to do that as a working mom as well.
Yeah, so Well-Woman MD, I created this company. Essentially, it's in the category of health coaching. There are certain things that don't have any real rules to them, right? So health coaching, you don't have to be a certified health coach to have a health coaching business. And so it's not medicine. I'm not diagnosing and treating on that in this business. I'm essentially providing them education. The definition of health coach is that these things are readily available to anybody on any resource, books, internet, wherever. You're just helping them guide them to those resources. So you're not making a diagnosis. I'm not saying to someone, you have PCOS, these are your options. They may come to me and say, I have PCOS, what can I do? to help me stop having acne, help me lose weight. So I guide them into the right kind of diet options, what they can do for their lifestyle and what they can do for mindset. Because a lot of this is really, it's hard. It's hard to make changes in life. So talking about mindset. So it's a little bit different than medicine because you're not trying to like diagnose and treat them. You're trying to essentially let them lead the way, and you're helping as a co-pilot and the cheerleader to help them through those journeys. So I did it because I have Hashimoto's, thyroiditis, and PCOS, and I had a really hard time getting pregnant with my kids. And I was just frustrated. I'm a doctor. I was a doctor then, and I, went to go see the fertility doctor, and they're like, yeah, it's all fine, good, labs are good, you're fine, just you know how to have a baby, like go do your thing. And I'm like, it's not working. Like, I'm an OBGYN, I know how to get people pregnant, it's not working. So I basically sort of forced the issue upon the doctor to test my thyroid antibodies, and found out they were in the thousands, which is really high. So essentially over 100 is abnormal, and mine were in the thousands. So, but my TSH and T4, the standard tests people do, were gorgeous. And so I ultimately ended up taking Synthroid, the medicine to help with Hashimoto's, and realizing that we don't know everything in medicine, right? We don't know, we don't have the perfect answer to everything, that sometimes people actually are sort of on their way there. Our tests don't essentially pick them up, because I was able to conceive my second son by doing that. And then I continued on that journey afterwards and realized that I was still feeling kind of crappy despite taking medication, and ended up going gluten-free from that standpoint, and learned that gut health and autoimmune are so incredibly important that for most people, they can't just eat what they want and think they're going to be feeling good. So I did that probably 10 years ago. I don't know, it's been a while, and I just sat on it forever. And this last year, this patient who I've known for all 13 years came to me, and she always calls me Dr. Jen. That's why I put my name up here, because she calls me, sometimes it doesn't matter what you say. People are like, hey, Jen, hey, they call you whatever. So, but I've had a good relationship with her for a very long time. And she was like, I know that you know the answer to my problem. Like, and I was like, I don't know. Like, I gave you birth control pills. It's not working. I don't know why I can't help you. And then it just clicked to me last year, I was like, why do I not share what I did myself to help other people? Why am I sitting here trying to fit the box of a normal doctor and be like, here's pills, it works or it doesn't? I'm sorry, I don't have an answer. I do have the answer. I just need to to share that, because I spent years like combing through PubMed and all these, resources to find out science-backed diet solutions, and I just didn't offer it to my patients. So that's why I created this company, to try to to help other women who were probably just as frustrated with me as I was with my doctor at the time, to try to make them feel like there is solutions. I just need to offer that. So that's why I did this. And balancing, when I have 4 kids, you are used to doing stuff at crazy hours I get up at 6 o'clock in the morning, I get on my little computer, I work on my business, then my kids come barreling down the stairs and want me to feed them. And then, at 9 o'clock at night when they go to bed, I'm working on this again. So I try to do it and fit it into the time that I have available, just like anything else. If you have other outside interests, you would do the same thing.
That's great. Thank you so much for sharing your own story. A lot of people found that very inspiring, so thank you for that. Another common question that we had was, people are wondering what the difference kind of is from lifestyle medicine. We've heard about it, so is there any overlap? Is it the same thing, different names? Or if you could kind of speak on that.
Yeah, so lifestyle medicine is so they focus on 6 pillars of health. So it's based upon, and usually it takes about 6 months or so to go through the program. So you do a lot of, it's an online course as well. You can get board certified. So you can essentially do the 6-month course, and then you can apply to take the board and be board certified in lifestyle medicine. Their approach is 6 pillars, and I am not a lifestyle medicine doctor, but essentially it's looking at the stuff that most of you guys know, like looking at stress, looking at sleep, looking at toxic environment. So things that you put on your body, not just in your body, looking at, what do they call it? Like essentially smoking, drinking, like bad habits, basically. There's a name for it. I can't think of it. And so you're essentially focusing on those 6 pillars. The people who created lifestyle medicine are plant-based. They really focus on plant-based, although there are many lifestyle medicine doctors who are, they call plant-focused. So they basically still, eat meat, but they predominantly focus on plant, because, if we were all plant-based, there would be no diabetes. Like it would, but it's hard. I'm not plant-based, but it's hard. So most of it is really sort of focusing on lifestyle factors and how you can change that. Integrative medicine is a 2-year fellowship. It's online. And what it focuses on, not only the lifestyle factors, but you talk about mindset. So you do a lot of mindfulness coaching, a lot of mindset coaching. We also learn about herbs and botanicals and how we can offer those things as medicine. And again, science backed. We're not going to go into I don't tell people I'm going to talk about crystals and wear funny shoes, or it's just not going to happen. Like, I want it to be science backed. And it's really sort of putting more of those integrative approaches in. The acupuncture is in there. So we learn about acupuncture techniques. You don't become an acupuncturist, but you learn about those things. So it's essentially providing alternative science backed options into your care. So it's marrying both conventional and alternative together, versus lifestyle is really focusing on those aspects of your lifestyle that need to change to optimize or prevent disease. Does that make sense?
Yes, thank you.
Okay.
Yeah, thank you so much for clarifying that, because I know a lot of people were wondering. Another question that we got was just, did you always know surgery was going to be a part of your career, or is it something that was a little daunting to you? Because there's a lot of people that are just kind of worried about the aspect of surgery, even though it's interesting to them.
Well, so what's so funny is I actually in medical school, I was going to be an ER doctor. I did ER rotations. I had all my letters in. I literally went to Oakland, California, in the middle of not a very pleasant neighborhood, and did CPR all day for gunshot wounds. Like, I was hardcore emergency medicine. Like, it was awesome. And my mother said to me, every single time you came home on your OB rotation, you were so excited. Like, you talked about it nonstop. And I was like, well, what do you mean? She's like, I think you're making the wrong choice. And I was like, Mother, you're killing me right now. Like, I have my letters in, I'm ready to go. I just literally have to hit the submit button for what is that, ranking. And I really spent some time thinking about it, and I was like, oh God, she's right. Moms are always right. And so I switched at the last minute and flipped to OB. And so, because I realized you could kind of create, a lot of, in OB, a lot of people who really love surgery end up doing GYN oncology, because that's what they do all day. They operate, they have hard cases. They're like the go-to person. If you can't get something done, you call your oncologist. So a lot of people tend to sort of find their little people within that group. REI tend to be people who like procedures, but they really don't want to do surgery as much. They really want their procedure kind of people. Maternal fetal medicine, they are mostly consults. So they sometimes have to do call, but most of the time they're consults. So they're an outpatient based practice. So you almost kind of find your little group within that world as well. So you can kind of decide you obviously can't be opposed. You can't be someone who's like, oh my God, I can't be in there, I'm going to pass out. That's not a good plan for being a GYN doctor. But in general, most people kind of find their people within that specialty too. And I think that's why there's so many different subspecialties in essence. So I think, as you go through medical school rotations, you usually tend to find what you like. So I went to the medicine rotation, like at the VA, and I was like, nope, not working with men, not working with old men, it was not my jam, not interested. So, went to pediatricians, the pediatrics, I loved the babies, I loved the kids, I thought it was great, but I was like, this is about some crazy moms. I don't know about this. There's some crazy moms in this place. So it just kind of, you find the people and you find the thing that really resonates. I always tell medical students that I talk to don't pick ahead of time, just be open to it all. You will totally figure it out when you're there, because you'll start gravitating towards what you're interested in.
Yeah, thank you so much. I know all of us over here are always confused about what we want to do, so it's good to know that we should just be open.
Yeah, don't pick it ahead of time. Like it will pick you, I promise. You'll just sort of resonate and go, yep, these are my people.
Yeah, I can at least speak for me and Lana. We definitely needed to hear that. I guess we'll end on a final question of if you could leave us with any last piece of advice as pre-med students, post-bac students, master students, in this lovely little pandemic that's hopefully going to be coming to an end in the next few months. Is there anything that you would leave us with to like get through this mess?
To get through the pandemic or just in general advice?
Whichever one feels better.
Listen, for the pandemic, we're all in it together. Trust me, it has been a pain in the ass. Like I mean, the one good thing is like actually on deliveries, it's just me and the patient and the husband, which is actually kind of nice. It's been nice not to have the crazy mothers and mother-in-laws and all the people that tell your birth story. So it's actually been kind of you kind of just have to look at the silver lining on some things. Like there are some bonuses, right? You and I get to chat. Y'all found me on Instagram. Like that's cool. Like there's some really cool, I made some great connections and learned more tech. I mean, like these are all some, you just have to phone. I actually have a podcast episode called I gave 2020 a 5-star review because I tried to like do that, is find the silver lining for what the good things that came of 2020. I taught my kids how to ride a bike. I mean, there's some bonuses. You just really have to think about it. For in general advice, and anybody who's on here, you guys are more than welcome to email me. I'll give you my cell phone. We can chat. Seriously, because I am the only, like when I was in high school, none of my family agreed with women having an education. I'm from a very Italian family where my father and mother didn't even go to my high school graduation. They were like, nope, you need to get married, have your babies, move on. So I went through it kind of alone. Like I went through this whole journey alone by myself, and it was very hard not to have other people that could say, you're not crazy. Like I wanted to go to college. I didn't know what I wanted to be. I had no idea. I had never been to a doctor. My other doctors I went to, I was a military kid, so you just stand in line. There's no such thing as like going to your doctor. You just stand in line until they call your name. So it's a lonely journey. And so I think you really have to follow your heart. You have to listen to yourself. And if it's something that says, this is where I was meant to be, just follow it. Just listen to what your gut instinct is. Because I promise, like, it's going to lead you the right direction. So you just need to listen and make sure that you just go for it. And if you need someone to be your cheerleader, I'm more than happy to help anybody through that, because I know it's hard when you're by yourself.
Thank you so much, Dr. Roelands. All your advice was awesome. Thank you so much. We all feel this was the inspiration we needed this morning to get us going.
Good.
Awesome. And yeah, if you open up the chat, you can kind of see all the thank yous, all the thank you.
I was trying not to mess it up. I already had my PowerPoint problem. I was like, I'm not touching anything. I'm going to hit the forward and backward button. That's all I'm doing today.
Perfect. Thank you so much for being here, and we'll keep in touch. And